Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 261 of our pharmacotherapy series, which majors in urinary tract infections. The first question reads, VOQ, a 20-year-old woman with no previous history of urinary tract infection, complains of burning on urination, frequent urination of a small amount, and bladder pain. She has no fever or costovertebral angle tenderness. A clean catch midstream urine sample shows gram-negative rods on gram stain. A urine sample for culture and susceptibility testing is ordered, and the results of a urinalysis are as follows. Appearance: straw-colored, normal, straw, specific gravity, 1.015, the normal range is 1.002 to 1.028, pH, 8.0, the normal range is 5.5 to 7.0, protein, glucose, ketones, bilirubin, and blood, all negative, normal, all negative, WBC, 10 to 15 cells per LPF, the normal range is 0 to 2 cells per LPF, red blood cells RBC, 0 to 1 cells per LPF, the normal range is 0 to 2 cells per LPF, bacteria, many, the normal value is 0 to rare epithelial cells, 3 to 5 cells per LPF, the normal range is 0 to few cells per LPF. Based on these findings, VOQ is presumed to have a lower urinary tract infection. What should be the goals of therapy of VOQ's infection at this time? What factors should be considered before selecting an antibiotic for VOQ? The goals of therapy for treatment of acute cystitis are to effectively eradicate the infection and prevent associated complications, while minimizing adverse effects and costs associated with drug therapy. To accomplish these goals, selection of a specific antimicrobial agent should be made after considering several factors. A. Most likely pathogens. B. Resistance rates within the specific geographic area. C. Desired duration of therapy. D. Clinical efficacy and toxicity profiles of various agents. E. Cost and availability of specific agents. And F. Patient characteristics such as allergies, compliance history, and underlying comorbidities. Because resistance rates among various pathogens vary considerably among geographic areas, clinicians must be familiar with resistance rates prevalent within their specific practice area. Drug treatment of a lower urinary tract infection often is started before culture and sensitivity results are known, because the most probable infecting organisms and their susceptibility to antibiotics can be predicted reasonably well. Approximately 75% to 95% of community-acquired infections are caused by Enterobacteriaceae, especially Escherichia coli. Although these organisms may be sensitive to ampicillin, amoxicillin, and the sulfonamides, such as TMPSMX, resistance to these agents is common. Ampicillin resistance occurs in 25% to 70% of community-acquired isolates. Resistance nationwide is currently about 30% to 40%. TMPS-MX has been a traditional agent of choice for many years. However, TMPS-MX resistance has significantly increased in recent years and may be as high as 20% to 40% among community-acquired Escherichia coli isolates in some geographic areas. Although traditionally associated with hospital-acquired infections, resistance among Escherichia coli and Klebsiella caused by production of ESBL enzymes which confer resistance to penicillins and cephalosporins has also been steadily increasing among community-acquired pathogens. Another relatively common organism is Staphylococcus saprophyticus. Most strains are susceptible to sulfonamides, TMPS-MX, penicillins, and cephalosporins. The next question reads, is it necessary to order a pre-treatment urine culture and sensitivity test for VOQ? Many investigators question the value of pre-treatment urine cultures for acute uncomplicated urinary tract infection. Women with lower urinary tract infection usually have puria on urinalysis and respond rapidly to appropriate antimicrobial treatment. Puria may be a better predictor of treatable infection than the colony count obtained on urine culture. Furthermore, the urine culture accounts for a large portion of the cost of treating a patient with a urinary tract infection. Consequently, in patients such as VOQ with uncomplicated, acute, lower urinary tract infection, it is more cost-effective to order a urinalysis and, if puria is present on urinalysis, to forego a urine culture. Instead, the patient should be empirically treated with a conventional course of antibiotic therapy. If VOQ remains symptomatic 48 hours later, a culture and sensitivity test can then be ordered. Considerations are quite different in patients with complicated infections. In complicated urinary tract infection, predisposing factors that lead to infection and frequent history of previous antibiotic use make both causative pathogens and associated antibiotic susceptibilities much less predictable. Use of culture and sensitivity testing is therefore commonly recommended for treatment of complicated urinary tract infection in order to choose appropriate antibiotics. The next question reads, what antibiotics may be appropriate for treatment of VOQ's infection? Updated IDSA/ESMID guidelines for the treatment of acute uncomplicated cystitis and pyelonephritis were published in 2011, and serve as the basis for selection of antibiotics in VOQ. The recommended first-line agents for treatment of this patient's uncomplicated cystitis include TMPS-MX, nitrofurantoin, and Phosphomycin Tromital. A fourth recommended antibiotic, pivmecylinum, is not commercially available in the United States. TMPS-MX is effective for therapy of uncomplicated cystitis. Gram-positive and gram-negative organisms, with the notable exceptions of Enterococcus, Pseudomonas aeruginosa, and anaerobes, are generally susceptible to TMPS-MX. Although TMPS-MX may appear active against Enterococci in vitro, clinical efficacy against this pathogen does not always correlate well and is variable. Individually, trimethoprim and sulfamethoxazole are bacteriostatic, but in combination they are bactericidal against most urinary pathogens. Furthermore, this combination is almost uniformly successful in the treatment of uncomplicated urinary tract infection, even against organisms that originally were resistant to either agent alone. Although rates of trimethoprim resistance have increased over the past several years, resistance rates remain relatively low in some geographic areas, and trimethoprim alone may be effective in managing urinary tract infection in many patients. The ratio of trimethoprim to sulfamethoxazole in the available tablet products is 1:5, e.g., 80 mg trimethoprim and 400 mg sulfamethoxazole. This combination has been chosen to achieve peak serum concentrations of the two drugs that approximate a 1:20 ratio. This ratio is optimal for synergistic activity against most microorganisms, although the drugs remain synergistic and bactericidal in ratios ranging from 1:5 to 1:40 in vitro. Urinary concentrations of trimethoprim and sulfamethoxazole far exceed the minimum inhibitory concentrations (MIC) for most susceptible urinary pathogens. Therefore, good in vitro activity, excellent clinical success which is similar to that of the fluoroquinolones and other alternative agents in susceptible strains, relatively low resistance rates among common pathogens, and low cost make TMPSMX a reasonable choice in VOQ. The 2011 IDSA/ESMID guidelines recommend TMPSMX as an appropriate initial agent of choice in the treatment of acute, uncomplicated lower UTI in geographic areas where the incidence of TMPSMX resistance among Escherichia coli is less than 20%. Nitrofurantoin is also recommended as an appropriate agent for empirical treatment of acute uncomplicated cystitis. Nitrofurantoin is almost completely absorbed after oral administration, but it barely reaches detectable levels in the plasma because it is rapidly eliminated half-life, 20 minutes into the urine and bile. The resulting high urine levels are 50 to 250 mg per liter and are well in excess of the MIC for most common pathogens causing urinary tract infection. Food substantially decreases the rate of absorption, but it increases the total bioavailability of nitrofurantoin from both the macrocrystalline capsules and the microcrystalline tablets by about 40%. This effect lengthens the duration of therapeutic urine concentrations by about 2 hours. Nitrofurantoin has a spectrum of activity which includes Escherichia coli, some strains of Pseudomonas, Staphylococcus saprophyticus, Streptococci, and Enterococci. On the other hand, Proteus, Enterobacter, and Klebsiella are more likely to be resistant with susceptibilities less than 60%. Nitrofurantoin does not significantly alter the fecal or introital flora, and the development of resistance in previously sensitive strains does not often occur. In contrast to ampicillin, TMPSMX, and other drugs with relatively high resistance rates, nitrofurantoin has maintained excellent activity against most uropathogens. Susceptibility rates among Escherichia coli currently range from 90% to 99% in most geographic areas. Finally, nitrofurantoin has been shown in comparative clinical studies to be as effective as TMPSMX, fluoroquinolones, or phosphomycin in the treatment of acute uncomplicated cystitis. Nitrofurantoin is thus recommended in the most recent clinical guidelines as an appropriate choice for treatment of uncomplicated urinary tract infection in patients such as VOQ. Most practitioners in the United States have little experience with phosphomycin tromital, but the drug has, nevertheless, been used quite successfully in the treatment of urinary tract infection in many other parts of the world. Phosphomycin is a phosphonic acid derivative which has been shown to irreversibly block bacterial cell wall synthesis through inhibition of early cytoplasmic stages of peptidoglycan synthesis. It has bactericidal activity against a broad range of gram-negative and gram-positive organisms including Escherichia coli and other Enterobacteriaceae, Pseudomonas aeruginosa, and Enterococcus as well as many multi-drug-resistant pathogens such as methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococci, and ESBL-producing gram-negative bacilli. Phosphomycin is approximately 40% absorbed after oral administration as granules marketed in a sachet form and is rapidly and almost completely excreted unchanged in the urine. Phosphomycin achieves mean urinary concentrations greater than 500 mg per liter within 6 to 8 hours after administration and maintains concentrations greater than 100 mg per liter for a duration of more than 26 hours after a single oral dose. Single 3-gram oral doses of phosphomycin are clinically as effective as trimethoprim and nitrofurantoin, although microbiological efficacy may be less. Nevertheless, phosphomycin is currently recommended for treatment of acute uncomplicated cystitis in the 2011 IDSA USMLE guidelines. It should be noted that although phosphomycin is commercially available in the United States, it is substantially more expensive than either TMPSMX or nitrofurantoin. Alternative agents for the treatment of urinary tract infection in VOQ include the fluoroquinolones and various oral beta-lactam antibiotics. The fluoroquinolones remain highly effective in the treatment of urinary tract infection. However, increasing rates of resistance among common uropathogens and the potential for significant collateral effects on normal flora leading to complications such as Clostridioides difficile infection have led to recent recommendations that the fluoroquinolones not be routinely used as preferred agents in the treatment of uncomplicated urinary tract infections such as that present in VOQ. Amoxicillin clavulanate and several oral cephalosporins have been studied for the treatment of uncomplicated urinary tract infection. These studies have shown the beta-lactams to be generally comparable to TMPSMX, but less clinically or microbiologically effective than the fluoroquinolones. Beta-lactams require longer durations of treatment, which makes them less attractive from the standpoint of ensuring patient adherence and may also predispose to higher rates of drug-related adverse effects. Finally, these relatively broad-spectrum agents may be associated with more frequent emergence of bacterial resistance, including ESBL-producing gram-negative bacilli. Thus, the beta-lactam antibiotics, with the exception of pivmecalinum, are currently only recommended for empirical treatment of uncomplicated cystitis when none of the other agents previously discussed can be used. Of note, ampicillin and amoxicillin are specifically discouraged for empirical treatment of urinary tract infection because of the high resistance rates previously noted. VOQ could be appropriately treated with either TMPSMX, nitrofurantoin, or phosphomycin. She has no apparent patient characteristics that would favor the use of one agent over another. In this case, the most important factor to consider would be local antibiotic susceptibilities among community-acquired uropathogens, particularly Escherichia coli. Local costs and availability of the different options would also be important to consider in VOQ. Note that the current IDSA USMLE guidelines do not apply to the empirical selection of antibiotics for complicated urinary tract infection. Complicated infections are often associated with more difficult pathogens, e.g., Pseudomonas aeruginosa, and increased risk of antibiotic resistance. Fluoroquinolones are therefore considered preferred agents for initial treatment of complicated urinary tract infection with subsequent antibiotic therapy guided by the results of culture and sensitivity testing. The next question reads, VOQ is started on TMPSMX for treatment of her infection. What would be the preferred duration of therapy of antibiotic therapy for VOQ? Outpatients with acute, uncomplicated urinary tract infection can be treated successfully with a traditional 7 to 14-day course of oral medications, a shorter 3 to 5-day course of therapy, or with single-dose therapy. The traditional 7 to 14-day course of antibiotic therapy now is considered excessive for most patients with uncomplicated infections and is seldom used. A 3 to 5-day antibiotic treatment regimen is just as effective as a 10-day regimen in achieving clinical cures and eradicating urinary tract organisms, although this is somewhat antibiotic class specific. TMPSMX is recommended as the preferred agent for 3-day treatment regimens. The fluoroquinolones may also be used in this shorter duration. A 5-day course of nitrofurantoin is as effective as a 3-day course of TMPSMX for acute uncomplicated cystitis, and nitrofurantoin is thus currently recommended as a 5-day regimen. Beta-lactam antibiotics are more appropriately reserved for longer treatment courses of 3 to 7 days. Longer treatment courses are also used in cases of treatment failure after regimens of shorter duration, as well as in the treatment of complicated urinary tract infection where longer courses of therapy, lasting 7 to 14 days, are associated with higher clinical success rates and improved outcomes. Even a single dose of an antibiotic may be effective. Bacteria disappear from the urine within hours after antibacterial therapy has been initiated. This, coupled with the urinary bladder's ability to defend itself through micturition, acidification, and inherent antibacterial activity, gives theoretic support to the clinical evidence that a large single dose of an antibiotic can eradicate a urinary tract infection. Phosphomycin Tromital is a perfect example of this principle. Very high urinary concentrations of this bactericidal agent are maintained for more than 24 hours after a single 3-gram oral dose and contribute to the favorable clinical efficacy observed in comparative trials. Although not recommended in the current guidelines, single doses of antibiotics other than phosphomycin are also occasionally used in treating acute, lower urinary tract infection in young women. Commonly used regimens are TMPSMX 2 or 3 double-strength tablets, trimethoprim 400 mg, amoxicillin clavulanate 500 mg, amoxicillin 3 g, ampicillin 3.5 g, nitrofurantoin 200 mg, ciprofloxacin 500 mg, and norfloxacin 400 mg. Again, choice of a specific agent should be based on local susceptibility patterns, patient allergies, and relative drug costs. Female patients with history or clinical presentation suggestive of complicated infection, e.g., systemic manifestations of infection, renal disease, anatomic abnormalities of the urinary tract, diabetes mellitus, or pregnancy, a history of antibiotic resistance, or a history of relapse after single-dose therapy should not receive single-dose regimens. Single-dose therapy is also not appropriate for male patients with urinary tract infection. Because VOQ does not have any of these contraindications, she could theoretically receive single-dose therapy with an appropriate agent. The advantages of single-dose treatment of urinary tract infection include improved compliance, reduced cost, proven efficacy in a defined population of patients, i.e., young women with acute, uncomplicated lower urinary tract infection, minimal side effects, and a potentially decreased incidence of bacterial resistance associated with antibiotic overuse. However, several concerns also exist regarding single-dose therapy. First, sample sizes in most comparative studies were relatively small. Consequently, it is difficult to determine whether differences in effectiveness or incidence of side effects between single-dose and multiple-dose therapy are clinically significant. Meta-analysis of studies comparing either single-dose or 3-day regimens with TMPSMX therapy has demonstrated that single-dose therapy is significantly less effective in eradicating bacteriuria than regimens of equal to or longer than 5 days, 83% versus 93%, respectively, with a p-value less than 0.001, or equal to or longer than 7 days in duration, 87% versus 94%, respectively. With a p-value equal to 0.014. Reduced microbiological efficacy was also observed with single-dose phosphomycin. Although fewer studies have directly compared single-dose versus 3-day therapies, numerous studies have shown that 3-day courses are as effective as courses of longer duration. Finally, single-dose therapies have been associated with higher rates of recurrence compared with therapies of longer duration. A 3-day on 5-day course of therapy is therefore currently recommended by the IDSA, USMLE for uncomplicated cystitis. A large single dose of phosphomycin is the sole single-dose regimen endorsed by the guidelines. Based on the preceding information, and according to current guidelines, a 3-day course of TMPSMX, a 5-day course of nitrofurantoin, or a single dose of phosphomycin would be most appropriate for treatment of VOQ's infection. When using short-course regimens, it is important to counsel the patient that the clinical signs and symptoms of infection may often not be completely resolved for 2 to 3 days after initiation of therapy. Therefore, symptoms that persist for a short while after beginning therapy, or actually completing therapy, in the case of single-dose regimens, are not necessarily indicative of treatment failure. The next question reads, along with TMPSMX, phenoxypyridine is also prescribed because of VOQ's complaints of significant dysuria. Is phenoxypyridine appropriate for this patient? Phenoxypyridine, a urinary tract analgesic, occasionally is prescribed alone or along with an antibacterial agent for the symptomatic relief of dysuria. Although phenoxypyridine at a dose of 200 mg orally 3 times a day may relieve dysuria, it is ineffective in the actual eradication of true urinary tract infection. Phenoxypyridine plus an antibiotic is not any better than an antibiotic alone, therefore, the drug is not likely of significant value in VOQ and should not be routinely recommended. However, although most patients have resolution of symptoms within 24 to 48 hours after beginning therapy, certain patients with severe dysuria or delayed response to antibiotic therapy may benefit symptomatically from a short trial 1 to 2 days of phenoxypyridine. The need for, and duration of, analgesic therapy must be individualized. Phenoxypyridine is an azo dye and may discolor the urine to an orange-red, orange-brown, or red color that can stain clothes. Other adverse effects of phenoxypyridine occur after acute overdose, or as a result of accumulation in older patients or in patients with decreased renal function who take the drug chronically. In vivo, about 50% of phenoxypyridine is metabolized to aniline, which can cause methemoglobinemia and hemolytic anemia. Hemolytic anemia associated with phenoxypyridine occurs primarily in patients with glucose 6-phosphate dehydrogenase, abbreviated as G6PD, deficiency. Cases of reversible acute renal failure and allergic hepatitis have also been rarely reported after brief exposure to phenoxypyridine. The next question reads, 2 days after VOQ begins treatment for her infection with TMPSMX, results of the culture and sensitivity studies become available and reveal greater than 105 bacteria per milliliter of Proteus mirabilis, which is susceptible to ampicillin, amoxicillin clavulinate, cephalosporins, and gentamicin. The Proteus is intermediately sensitive to nitrofurantoin, and it is resistant to TMPSMX and ciprofloxacin. VOQ reports that she is symptomatically better since starting antibiotic therapy and that her dysuria and bladder pain are now almost completely resolved. How should these test results be interpreted? Is a change in VOQ's antibiotic therapy necessary? Most women with either lower or upper urinary tract infection have greater than 105 bacterial colonies per milliliter of urine. However, a major revision in the diagnostic criteria for symptomatic urinary tract infection has been the abandonment of the absolute requirement for growth of equal to or more than 105 bacterial colonies per milliliter of urine. The criterion of greater than or equal to 100 bacteria per milliliter results in excellent sensitivity and specificity in correctly diagnosing and treating women with symptomatic infection. This same criterion should also be applied to lower urinary tract infection when Staphylococcus saprophyticus is isolated, because urinary tract infections caused by this pathogen often are associated with low urine bacterial colony counts, suboptimal growth on commonly used media, and negative findings on nitrite screening. Mixed flora, that is more than two organisms, is unusual except in severely debilitated persons and other complicated infections. Thus, mixed flora in the setting of uncomplicated infection frequently suggests contamination, and a repeat specimen should be obtained. Bacterial susceptibility to different antimicrobial drugs is usually determined by referencing interpretive criteria that correlate with achievable serum concentrations of those drugs. However, drugs useful in the treatment of urinary tract infection are excreted primarily by the kidney, and urine concentrations of these drugs may be 20 to 100 times greater than serum concentrations. Therefore, infections caused by organisms that are only intermediately susceptible, or even resistant to the tested concentration of antibacterial drug, might still be effectively treated with the high concentration of drug achieved in the urine. Although in vitro susceptibility testing is not always predictive of patient response to therapy of urinary tract infection, studies clearly show that patients infected with a resistant pathogen are at increased risk of treatment failure. Clinical response to infection occurred in only 24% to 61% of patients with organisms resistant to TMPSMX compared with 83% to 92% of patients infected with susceptible organisms. Furthermore, patients infected with TMPSMX-resistant pathogens were 17 times more likely to fail therapy compared with patients with susceptible strains. Patients treated with TMPSMX, who were infected with drug-resistant organisms, were also found to have longer median times to symptom resolution, 14 versus 7 days, with a p-value equal to 0.0002, more frequent return clinic visits within 1 week, 36% versus 6%, with a p-value less than 0.0001, more frequent need for subsequent antibiotic therapy, 36% versus 4%, with a p-value less than 0.0001, and higher rates of significant bacteriuria after 1 month, 42% versus 20%, with a p-value equal to 0.04. Although up to 75% of patients with resistant organisms may experience failure of TMPSMX therapy, antimicrobial therapy is usually chosen empirically without the benefit of culture and sensitivity testing results. Appropriateness of antibiotic therapy is, thus, usually judged according to subsequent clinical response. If the infecting organism is susceptible, the urine will usually be sterile for 24 to 48 hours. If a urine specimen collected 48 hours after initiation of therapy is not sterile and the patient has been taking the medication properly, the antibiotic may be inappropriate or the focus of infection may be deeper, e.g., pyelonephritis, abscess, obstruction. If the urine specimen is sterile and the patient is symptomatically improved, the appropriate antimicrobial is being used, regardless of susceptibility studies, and the full course of therapy should be completed. Because VOQ reports significant improvement in her subjective symptoms, her 3-day course of TMPSMX should be completed as originally ordered and VOQ should be closely monitored for any evidence of relapse. A repeat culture and sensitivity test should be performed in the event that VOQ reports any new signs or symptoms which are consistent with antibiotic failure and relapse of her infection, and a different antibiotic should be selected for treatment at that time. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 262.